I did my medicine in France, in Toulouse, the general medicine. My specialty in Montpellier and in Paris. And I was in Minneapolis, in Twin Cities Scoliosis Center. I work with Bradford and John Moe, and the very big specialized people concerning scoliosis. It is Twin Cities Scoliosis Center. It's a very high specialized center for scoliosis at this period. We were doing around 3,800 spinal surgery per year. Actually, I am in Beirut, working in sometime in private hospital, but mainly in governmental hospital, because I like to treat the people which don't have the possibility to be treated in the private sector. And in general, the most interesting cases are in the public sector, not in the private sector. When a patient came and have a problem of limping, it's very important to see what is the cause of the limping. So the child have to be without clothes, just something to cover. And we have to see if there is a Trendelenburg gait, if there is a cover sign, if there is a spastic gait, if there is a short limb gait, and it's important to see if there is pain or no pain, fever or no fever. So we are going to see first limping without fever. For example, we will talk about inflammation or infectious disorder concerning the hip. Transient synovitis is common in child between 3 and 8 years old. But transient synovitis, there is moderate pain in general. Child can continue to walk without a major problem. Fever is in general moderate, not more than 38 degrees. Diagnostic can be easy. Clinical sign, there is good mobility, moderate pain. If you do a blood test, in general, all blood tests are quite normal. Normal X-ray can show moderate accentration of the hip if you compare the side of the pain and the opposite side. Ultrasound can be helpful. In transient synovitis, no need to do an MRI or a CT scan, it's too much. So in general, the treatment is bed rest, small anti-inflammatory, make less activities, and it will be okay, can be in 3-4 days or can be in 10 days. The main problem is when you have hip pain, limping, and very high fever. So we have to rule out a septic arthritis. Septic arthritis is very important because we have to know that if the diagnosis is too late, the consequences are going to be very bad, especially in a small child, because we will have a head destruction of the femoral head. We will have later on complication like leg discrepancy because the growth plate of the proximal femur is around 30% of the remaining growth. We will have stiffness and pain. So it will become very complicated later on for the treatment, and it will be a big handicap. So it's good to have a very quick diagnosis because we will start an antibiotic treatment. Mainly, all the blood tests are positive in general. The only kind where there is no blood test positive is when patients have immunodepression problem. So a disease parallel. So white BC is very high, ESR, CRP. Don't wait for the excentration of the hip in the normal X-ray because it's a little bit too late, it will become chronic. So if you have any doubt that there is hip septic arthritis, please do an MRI, you do arthrotomy, you clean up, and you start antibiotic. In general, infectious is 70 to 80% is Staphylococcus aureus. So you will start your treatment, and in general, when you start it early, you will have a very good result. We have another problem is osteomyelitis. Osteomyelitis is something very important. You have pain. Sometimes pain is very severe. Sometimes if osteomyelitis is late diagnosed, you will see the child in postural flexion abduction hip because the pain is like a fracture. So diagnostic must be early, especially in the hip, because the growth plate is intra-articular. So when you have infection of the hip, in general start metaphyseal, because the metaphysis is intra-articular on the hip, it will become very quick a septic arthritis. It's a difference with the knee, because in the knee, especially in the tibia, the metaphysis is extra-articular, so it's much later you will have a septic arthritis of the knee. So the diagnostic of the hip have to be done very quickly, and you have to start your treatment. Like the septic arthritis, you have to do your blood test. You have to do, if you have any doubt on your diagnosis, scintigraphy or an MRI, and start the treatment to avoid bone destruction and problem later on with the joint. In general, actually we see a lot of Staphylococcus aureus and methicillin resistance recently. So we need to have a quick treatment, because quicker it is, better result later it is. Sometimes limping is secondary to discitis. Child have a back pain. He can walk, but if you ask him to bend, bending is very difficult because he feel pain. So you have to do your blood test, your examination, and at the same time, normal standard X-ray can show you narrowing of the disc space. So if you have any doubt, you can do MRI or a scintigraphy. In my experience, rarely I do a needle biopsy or an open biopsy, because we can treat it without this act, which can be difficult. So if we do an MRI or if we do a scintigraphy with a blood test and with a clinical examination, if you don't have any neurological trouble, everything is normal, only fever and pain, you can start your treatment, and generally you will have a very good result too. Discitis is very well treated. We don't have a big problem. And like any osteomyelitis, it's 80% of Staphylococcus aureus. If after a period of treatment, you will feel that the result is not like you feel it's good, you can make a B therapy. But in general, anti-staph, mainly it's a good treatment. Sometimes limping is secondary to juvenile arthritis. Juvenile arthritis, generally, it's concerning the knee and the ankle. You do your test, and if you feel that it's a juvenile arthritis, please don't start to treat it. We are orthopedists. You have to send it to the pediatric, specialized in rheumatology, and don't treat it. It's better. Sometimes we have limping because there is neurological disorder. It can be a cerebral palsy. We are not going to talk about cerebral palsy today. It's not our subject. But we have to rule out a neuromuscular dystrophy. Neuromuscular dystrophy can occur early between 2 and 5, and sometime later on. So we have to do some tests. The main test is the Gower test. We have to examine the hip, the ankle, and the knees. The Gower test is very important. He will give you very early diagnostic. You will see that sometimes you have a pseudo hypertrophy of the calf. And if you do a blood test, the creatine phosphokinase CPK can help you. Limping can be secondary to anatomic disorder like DDH, or Coxa-Vara, Legg Calve disease. So we have to talk a little bit each case. When you have a DDH, in my experience till today, I am seeing a lot of DDH diagnosed only after walking age, which is not very good. So I advise all the pediatricians, when you examine the child, please, in any way, do a hip X-ray at 4 months of age for all your child once. Because if you have a dislocable hip, you can feel it. But if you have a severe secondary dysplasia or primary dysplasia, you will not feel it with your test. And later on, the child will start limping when he starts walking. So we can do early diagnosis for better treatment. I advise for all the child, and especially the girl, because we know that the girl are 9 times more have hip dislocations than the boys. So it's better to do an hip X-ray at 4 months once. And if there is any hip dislocation, we know the treatment. We are not going to make a detail of this treatment. The Coxa-Vara is in general something congenital. You will see that in general it's bilateral. And the child, when he walks, he have an hyperlordosis. Before to talk of the Coxa-Vara, one point is important. When you have a bilateral hip dislocation, sometimes because it's symmetrical, even when the child walks, the diagnostic is difficult. The parents will not do the remark saying child is limping. So when it's bilateral, sometimes it's later diagnosis. So it's better when it's bilateral to do an hip X-ray early too for the treatment. Coxa-Vara, in general, you will see that the cervicodiaphyseal angle is very short. And you will see that the metaphysis is parallel. It's vertical. You have to follow up. During the follow-up, in one time, you have to do maybe osteotomy of valgization to have a better development of the hip. Progressively, you can follow the child, and when you see at one time it's time to do the surgery, please do the coxa-valga osteotomy. Limping can be secondary to slip femoral capital epiphysis. Or before this, we can talk about the Legg Perthes Calve disease. Limping, Legg Calve disease limping, it's important. It's happened in general between age of 2 years to 12 years. Sometimes it's very early. So it's good to do a diagnosis very early and to follow up the child. In general, don't be aggressive with your treatment. Sometimes I say a special bracing. In general, I don't do all this. I just say to the parents, please let the child walk, not run, not jump, can swim, can play bicycle, and we will do an X-ray follow-up every 4 months. Progressively, if we see an accentration of the femoral head, we will have to do a surgery to make a better congruence between the femoral head and the acetabulum. The surgery will depend on the aspect of the head and the acetabulum and of the age of the patient. If you have a coxa magna, don't do osteotomy of varization because you will aggravate the situation. If you have a normal hip, not a coxa vara, not a coxa magna, don't do osteotomy of the varization. Osteotomy varization is when you don't have a coxa magna and when you don't have a coxa vara. So you will play at the acetabulum side. Acetabulum side, you have to make the acetabulum bigger. So you have different technique. I use sometimes the technique of styly. Styly, in some case, it's a good technique. If you have an accentration without coxa magna, you can do osteotomy of varization. Slip femoral capital epiphysis. Slip femoral capital epiphysis is very important to do an early diagnosis because it can be worse. Progressively, the head will be luxate posteriorly and medially. So you will see during your examination that there is limitation of the internal rotation. Internal rotation is very stiff. You do a standard X-ray. When you do a standard X-ray, you can see if there is a slip femoral capital epiphysis or not. You do a claim line. A claim line will show you if you start to have a slip femoral capital epiphysis or not. So if they start, it's better to fix the hip. You fix it in general with one cannulated screw. I don't like to put 2 or 3 cannulated screws. One cannulated screw in general, it's enough. Some people ask to do a bilateral because there is possibility of bilateral slip femoral capital epiphysis. I don't advise that because it's better to do it on time because there is a lot of patients, they have only one side. So why to go and to fix the other side? There is always risk in surgery because when you put a cannulated screw, you never know if you will have an AVN later on or not. There is also a problem with chondrolysis. Chondrolysis can happen in children who have dysplasia, severe dysplasia of the hip, and later on will develop a chondrolysis. Secondary to DDH or secondary to slip femoral capital epiphysis. This problem is really not easy to treat. It's very annoying because you will never have a good result. So you have to be very moderate on your treatment. Do the good treatment without excessive surgery. In general, always you will have a bad result. So be in the safe side, don't be aggressive. Okay, we can see the different things. For example, the toddler fracture. Sometimes you have a child, when they walk, they have a mild fracture of the tibia, not concerning the fibula. Sometimes you cannot do your diagnostic because on the standard X-ray, sometimes it's very, very small line. You can't see it. Maybe you will make the diagnosis 2 weeks later because they will start to have periosteal reaction. So you can see it. If you want to do an early diagnosis, you need to do a CT scan or an MRI, but sometimes it's not necessary, it's too excessive. If you are in a country where the medicine is not very expensive, it's very expensive, you do a cast. You do a cast for a short period, and after that you remove the cast. When you will do a X-ray, a standard X-ray, you will find later on that you will have a hyperreaction of the periost. So you will know that it was a small fracture. We call it total fracture. Sometimes you have child coming and walking. They have limping, but limping is secondary to tarsal coalition. You will see it's very important. It's a stiff, everted flat foot. You examine the foot, you will see that when you do a plantar flexion, it's painful. When you try to do a varization, it's quite impossible. It's stiff. So the tarsal coalition in general, it's concerned the calcaneonavicular bridge. You have a calcaneonavicular bridge. And this bridge, you can see it in the oblique view. And if you have this kind of tarsal coalition, in general, you do a surgery. A surgery, it's not complicated, it's easy. And you will put on the empty space fat. And it's more than enough. And in general, you have a good result. The more difficult are the talocalcaneal coalition. It's more difficult, more complicated, because the joint is very small and it's a weight-bearing joint. So later on, maybe you will need, if you do the surgery, to do a fusion. The fusion will avoid later on the pain. Okay. We can talk about the leg discrepancy. You have always limping secondary to leg discrepancy. When you have a leg discrepancy, you have to do a scanogram. When you do a scanogram, you will see where is the shorter part of the leg, where is the taller. You have the femur, you have the tibia. One point is important. When you have a leg discrepancy, not diagnosed, later on, some child can develop scoliosis. Scoliosis is secondary to pelvic tilt, and later on, with time, it can be structural. At the beginning, it's not structural, but later on, non-treated, it can be structural. So it's good to know if there is a scoliosis associated. You do an X-ray standing, plus X-ray standing with compensation. You will see that the spine will become straight without vertebral rotation. So you will know that the limping is the scoliosis is secondary to the short limb, to the short limb. If you have a leg discrepancy, depending on the case, there is very complicated case. The complicated case are if you have a congenital short femur. This is complicated case because the difference is sometimes very big and sometimes can be associated with hip dislocation. So if the child is very small, you can use a brace and wait for the time when he is older to do some surgical compensation. If you have a normal leg discrepancy without deformities, you can, at the age, precise age, do a surgery to stop the growth of the higher limb. The limb which is longer, you will do a growth arrest. You will do a medial and lateral stapling of the distal femur and proximal tibia. After seeing when to do it, you will have to follow up to see the bone age, how remain of the leg discrepancy, what is the time for fixing. So it's important to do a follow-up. Don't rush. Do an X-ray once every 8 months, every 1 year. See if it's a progressive leg discrepancy or non-progressive leg discrepancy. Sometimes you have a leg discrepancy which stay fixed. Some will increase with time. The one who will be increased with time, you have to choose the time to do a growth arrest to allow the opposite side to compensate. Sometimes we have a problem limping secondary to neoplasm. Pay attention to leukemia, Ewing sarcoma, neuroblastoma. Sometimes limping is secondary to this kind of disease. So we are not going to talk about that. We will talk about a benign tumor, like for example, osteoma. If you have an osteoma, frequently is on the hip, on the knee, on the ankle. On the spine is an exception. So when it's on the hip, you can see there is a loosened part and sometimes reaction surrounding the nidus. If you have any doubt, you do an MRI and you will see very good point of the nidus. And before we were doing surgery, resection and bone grafting. Today, no, we don't need. Radiofrequency will do very, very well. Radiofrequency is excellent, not aggressive. We stop to do this kind of surgery. So when you have an osteoma, when you want to do a treatment, better to do it with a specialist in a specialized radiologist, interventionist. He will do the radiofrequency, it will be perfect. Osteoma, sometimes I saw osteoma concerning the spine. It's very rare. It will give you a false scoliosis, but it's scoliosis with pain. In general, scoliosis, there is no pain. Pain will be later on, secondary to arthrosic problem. At the beginning, if you have any child with scoliosis and pain, you have to rule out a spinal dysraphism or an osteoma. I have only 2 cases of that. It's the same, very good result if they do a coblation. It's perfect. You will have excellent result. I'm going to show you some picture, just quick, and we will finish. Hassan. Okay, this is one case. Like you can see, this is a Perthes disease. Beginning at the left side, fragmentation. Later on, femoral head is healed completely. It's not always the case. Sometimes the case can be very bad. This is a case 8 years later, a different case when you have a coxa magna and subluxation of the femoral head. This is a slipped femoral capital epiphysis. You can see the claim line will give you the diagnosis. This is an example. It's beginning at the left side, stage 1, and now it's completely luxated posteriorly and medially. This was fixed by 2 screws. I will advise 1. It's better. Sometimes you are obliged, when patient came too late, to do an upon reduction, an osteotomy and fixation. This is the osteochondrite dissecant of the knee. This is a different place where you can find it. This here, in general, this is a radiolucency saucer-shaped line. It was treated by fixation by Herbert screw. Sometime I forgot to talk about it. It's the epiphysis of tibial tuberosity, Osgood Schlatter disease. In general, people are afraid when they come and talk about the mass on the tibia. They think that this is a tumor. But in general, you ask the child to do less sport activity and in general, anti-inflammatory, and with time, it will resolve with growth. I never treat operatively any Osgood Schlatter in my experience. You have osteochondritis of the talus. It's not frequent. This is a different stage that you can have. And this is after excision of the osteochondritis at the left side, and it will become normal later on. This is something that you can see always in child 2, 3 years old, 4 years old. Collar disease. This is osteonecrosis of the navicular. The results are excellent in general. It takes sometimes several months. Few of them will need a casting, never surgery, and it's always an excellent result. This is for leg discrepancy, is a kind of brace that you can put if you have a femoral congenital short femur. And this is a kind of surgery for gross arrest that you can do. And this is, for example, to finish, an osteoma of the vertebrae. Okay. This is an osteoma of the femur. Look at the MRI. This is for the tibia. You can see the medial side, there is hyperreaction and condensation. 20 years ago, we did a resection, but now we will not do it. We will do it only by radiofrequency. Thank you.